Good afternoon, everyone. It's both an honor and a responsibility to welcome you to this webinar hosted by Aorna in collaboration with Striker, dedicated to the theme creating a safer operating room, protecting nurses, patients, and the environment. My name is Manuel Valente. I'm from Portugal. I represent my country on the Aorna Board of Directors. Today, we gather as perioperative nurse and healthcare professionals who share a common goal, ensuring safety in one of the most complex and high-risk environments in healthcare, the operating room. The focus of our debate, surgical smoke and biological fluid management, may seem purely technical, but its implications are deeply human. Every day, perioperative nurses and perioperative support staff are exposed to invisible yet harmful risks. Surgical smoke, generated by the use of energy-based devices, contains toxic chemicals, viable cellular material, and virus. Prolonged exposure has been linked to respiratory problems, eye irritation, and even long-term potential carcinogenic effects. Yet, in many operating rooms across Europe, smoke evacuation systems are still not standard practice. Similarly, the handling of biological fluids, blood, irrigation waste, or other bodily substances pose not only infection risk but also ergonomic and environmental challenges. Manual fluid disposal methods increase the likelihood of spills, contamination, and musculoskeletal injuries, especially for perioperative support staff who often manage this task under pressure. These are not abstract concerns. They are daily realities that affect our colleagues' health, our patient safety, and the sustainability of our health systems. And they demand action, not only through innovation and technology, but also through education, policy, and cultural change. This webinar is part of that change. Over the next hour, we'll hear from two European distinguished specialist nurse professionals. First, Karam from France is a certified operating room nurse, I bought, with a career spanning surgical wards, intensive care, and heart surgery. She earned her operating room nurse specialist diploma in 1998 and has since worked in both the Central Sterile Supply Department and the operating room. May is also a former past president of EORN, associate editor of the French Journal of Operating Room Nurse, Interblock, and co-chair of the Surgical Smoke Coalition. She is passionate advocate for perioperative safety and education. And a second presentation will be made by Bodil and Helland from Norway. She is a perioperative specialist nurse at Flekkefjord Hospital in the southern of Norway, and an academic contributor whose work includes research on surgical instrument setup during emergency procedures. Her insights bridge clinical practice and evidence-based improvement in OR safety, particularly in high pressure scenarios. Before we begin, a quick note for all attendees. If you wish to ask questions at the end of the presentation, please submit them exclusively through the question and answer tool in Zoom application. This will help us manage the discussion efficiently and ensure that your question reaches the speakers. Let us use this time to reflect, to learn, and above all, to advocate for ourselves, for our teams, and for the future of perioperative care. Thank you for being here, and let's begin. Please, May.
Thank you, Manuel, and good afternoon, everyone. So, operating rooms require special caution because of various risk factors and hazards for healthcare professionals. The two subjects, as Manuel mentioned, of our topic are surgical smokes and fluid waste. You see this picture and you all know that acrid smoke that is produced during surgery. Where does this smoke come from? From electro devices used during surgery, like lasers, electrosurgical units, ultrasonic devices, high-speed drills and burrs, etc. So healthcare professionals are thus exposed to it. The risk associated with these fumes are dose-dependent and therefore depend on the intensity of exposure of professional, which is influenced by several factors like type of procedures, surgical technique, equipment used, duration of the procedures, the patient morphology, the air circulation in the room, the personal protective equipment worn, and the presence or not of a fume extraction system. Regarding the composition of surgical smoke, so it's mainly made of water vapor, so up to 95% of the smoke. And then the other components are in the 5%. It's a mixture of toxic substances, particles, chemical and biological compounds, the composition of which varies greatly depending on the technique, type of use and operation. These include biological active elements like cells, bacteria, viruses, and carcinogenic, mutagenic, and reprotoxic substances. For example, you have in the corner of the slide benzene that irritates eyes and can cause cancer according to the European directive mentioned here on the slide. And here is a study showing a more detailed description of what surgical fume contain. So what are the parameters influencing the composition of surgical fume? So we said energy sources and type of instruments, for example. It has been shown that the smoke generated by electrocoagulation contains more particles than the smoke from laser device and approximately 4 times the number of smoke particles generated by ultrasound. Second, the treated tissue. If it's adipose or liver, hepatic tissue, it's produce more smoke than skin. The skin produce less particles. And also the proximity to the emission source and the quantity of particle emitted, and therefore the concentration in the air also depends on the distance from emission source. More reassuring news, you all heard about this, you know about this problem, that a study said that on average, the smoke produced daily in an operating room is equivalent to 27 unfiltered cigarettes. What are the risks to the surgical team? So the smoke is inhaled and deposited in the pulmonary tract, and we can have irritation of eyes, respiratory tract, and skin associated with asthma and chronic pulmonary diseases, and also mentioned headaches and nauseas. EORNA and Stryker have conducted a survey in 20 and 21 among more than 500 professionals to investigate awareness level of surgical plume by hospital staff. And this study showed that 60%, among others, showed that 60% claimed to never have received information on surgical smoke and associated health risks. This was in 21. I hope the number, if we do the survey once more, the number will decrease. Here are other studies showed that we have increased rates of allergy, sinus problem, asthma, and bronchitis. And another study also rates of high rates of pregnancy complication and infertility compared to the general population. Other cases known in the literature, a Norwegian laser surgeon developed a laryngeal papillomatosis on his vocal cords because of the exposure to the surgical smoke. And another orthopedic surgeon had double lung transplant because of the smoke. There are protective measures for the surgical team, like ventilation, masks, fumes, extraction devices, information, special filters, but this will be developed by my colleague, Mrs. Helland. We have a lot of literature about smokes. So the danger of surgical smokes have been subject of discussion and studies since 1980s, the 1980s. This means 45 years ago. New studies continue to be published regularly. We just type surgical smoke and you have a lot of articles. EORNA has best practice for surgical smoke management. ESNO developed with EORNA also a guide for smokes. And do we have regulation for surgical smoke? An example for France, we have regulation that we have to maintain the atmosphere sufficiently pure for workers, for health workers. And but nothing speaks about surgical smokes. We have fresh air, recycled air, but nothing on surgical smoke. But in Denmark, since 2001, they have legislation to have a smoke-free operating room through a decree containing specific provisions. It says, it says that other unpleasant air contaminants, if other unpleasant air contaminants occurs, an extraction system must be installed to remove contamination as much as possible from the site where it is generated. We have this only in Europe, in Denmark. In the United States, for more than 10 years, E.ON has been working tirelessly to achieve smoke-free operating rooms. Till now, the first state who had legislation is Maine in 2018. Today, there are 20 states that have introduced legislation required the source evacuation of surgical smoke, and 9 states are still doing a procedure to obtain legislation. Here is the map to show. And about the European Agency for Safety and Health at Work, workers should work in healthy places, but no mention of surgical smoke neither. So in Europe, we have EORNA and Stryker, we have created a surgical smoke coalition. It's a pan-European initiative bringing together various stakeholder organizations concerned with surgical smoke and the dangers it poses to the surgical team. The current member today of this surgical smoke coalition are 12. Here they are. And the mission is to minimize the risk associated with exposure to surgical smoke, particularly for healthcare professionals working in operating room. This publication from the Surgical Smoke Coalition can be found on the website of the Surgical Smoke Coalition. And what we did, we tried to reach the European Parliament to obtain regulation. It has been very difficult, and we met individually MEPs also to obtain legislation and recommendation. But it seems to be very difficult to come from up to down. So we have been advised, and the best way, it's to come from bottom. It's a bottom-up focus. So we go from the national focus, and it will be the most effective path to change. So we begin on the ground and we go up and we may obtain regulation. We have an example in France that ANSES, it's a government body, and it is now working since February this year, 25. They have a team and they are working to find to find solutions and bring regulation or recommendation for smokes. Let's go now to the surgical fluid waste. You all know that healthcare facilities create a tremendous amount of waste that includes solid, fluid, and often biohazardous medical waste. This waste also has a higher potential to cause infection and injury than the waste in any other industry. Operating theaters are major sources of waste, accounting for 20 to 30% of all waste produced by healthcare facilities. Here are the different specialties where a big quantity of fluid waste is produced: urology, gynecology, obstetrics, cardiology, orthopedics. The OR is responsible, as we said, for 30 to 70% of hospital medical waste. And 40% of this waste is related to suction canister disposal. 33% of medical supply costs, and a largest cost related to waste management. So, and 5% of all medical waste is hazardous. What are the causes of adverse events associated with medical suction? We have the human errors, negative pressure, problems, infection related to device use, infection related to fluid waste, and ineffective suction system. And the human errors, it could be low protection compliance during disposal. The staff may overlook what is considered as minor detail. Despite training, 17% of those disposing of waste do not follow proper protocols. Up to 24% do not wear gowns or facial protections. And every time a worker pour fluids from a canister into a drain can cause exposure, direct contact. So this may do direct contact, inhalation, and just note that aerosolized germs and fecal matter can plume as high as 15 feet. This means up to 4 to 5 meters. So the potential consequences of exposures are health problems, time, you have the initial care, the follow-up, and testing for seroconversion, the cost, loss of time away from work, the working days lost, testing procedure, treatment, and psychological risk like anxiety and fear. Here's are some pictures. You might know that from spilling biological fluids, and they are holding this. This may cause musculoskeletal problems because it's heavy, and this third image, it's also a risk for the people who manage the waste. According to the World Health Organization, improperly managed medical waste can put patient, staff, and community members at risk of infection, toxicity, and environmental damage or contamination. So, just a reminder, the chain of infection. You know that fluid waste means presence of infection risk. It involves two elements. The fluid waste is a route of entry for the germs into the human body, airborne, digestive, percutaneous, and transmucosal. So the stuff is at high risk. So in order for infection to occur, several things have to happen. This is often referred to as the chain of infection. So we have 6 links: the infection agent of the microorganism which can cause disease, the reservoir or source of infection where the microorganism can live, portal of exit from the reservoir, mode of transmission, portal of entry. This shows the infection enter another individual. Susceptible host, this could be you, me, anyone in the OR or in the medical professional, healthcare professionals. This describes the person who is vulnerable to infection. So it's all of us. Can we break this chain? So infection can be prevented by breaking this chain. The way to stop germs from spreading is by interrupting it at any link. Break the chain by cleaning our hands frequently, staying up to date of our vaccines, this we all know, but in operating rooms, by using personal protective equipment the right way, cleaning and disinfecting the environment, sterilizing medical instrument and equipment, and using respecting the protocols of managing waste and equipment. We have some recommendation and guidelines from the United States. So in order to prevent all these problems, we need intensive up-to-date education on occupational risk, and employee safety should be provided for the staff working in operating rooms, and different precautions should be taken. And what the guidelines in the US says that we should install automatic fluid management system that flush blood and body fluids directly into sanitary sewer to increase personnel safety, to decrease the amount of disposals, and to offer long-term cost reductions. Here are some references. And I would like to thank you for your attention.
Thank you very much, May. The next presentation will be made by Bodil and Helland. And I think that we have a huge opportunity to clarify things with these two specialist nurses. Please don't be shy and ask any kind of doubt in our question and answer, please. Please, Han, it's your time.
Yes. Thank you. It's a pleasure to be here with you. And now I will present to you the equipment we use for liquid waste management and what we use for smoke evacuation. And I will start with waste management systems, also called surgical suction units. So here you see what was most common to use in the OR where I work until approximately 2 years ago. I call it surgical suction canisters. They can be used for most operations. They take 3,000 milliliter of liquid. You adjust the suction pressure manually, and in that way it is not that precise. You are easily exposed to liquid when changing chambers. And it is a lot of weight to carry for the cleaning staff when changing the canisters and sorting it in yellow boxes for special waste. And yes, in my hospital, we sort it as special waste, but some of you might pour out the fluid into the drain. Yes, and this is the waste management system we use for hysteroscopy. It sort of uses the same canisters as the regular surgical section I showed you in the previous slide, but I just wanted to show you this one as well, because it connects in series. So when it gets full, it automatically starts filling up the second chamber. It has one side for the outflow and one for the working instrument. On the side for the working instrument, you can put on a small box on the top where the test material will be collected. This small box you can put formalin on, close and send to histology without any need for changing to another preparate box. It has a built-in weight, so it calculates the deficit. But you have the same problem with easily being exposed to liquid from the patient when changing chamber. And this also has to be sorted out as special waste in my hospital. 2.5 years ago, we got this closed waste management system. Here on the picture, it is used for shoulder arthroscopy. So that is why the picture is a bit dark. I'm sorry for that. It has 2 chambers, so it is very practical if you need 2 different suction pressure. And when it needs to be precise for the instruments to reach their pretension and for the pump to work as it should. The pump we use, then the pressure should not be higher than 50 millimeters of mercury. So then we put the hose from the arthroscopy pump to one chamber, and the hose from the bag around the shoulder we put in the other chamber. Then we can turn this one on a higher section if we need more power here. And that is a large benefit for us and the surgeon. And it can contain a lot of liquid before it gets full, 24 liters at the most. That removes one stress factor for us during the procedure. Before, we had to change a lot of canisters during shoulder arthroscopy, and it was stress when it all of a sudden got full in a not suitable moment. Now we just have to pay full attention to the bags with sodium chloride and change them in time so the pressure in the shoulder remains constant. We love to use this system for arthroscopy, prosthesis, and cesarean section, but we use it for more and more of our procedures that needs a section in use. So as you already can hear, we are satisfied with this solution. We don't have to switch chamber on the suction all the time, and we don't get in touch with the liquid from the patient at all, and less liquid on the floor to clean. Also, the cleaning staff are protected from the liquid and from carrying a lot of kilos of liquid, because you see here it has wheels, so it's easy to roll around, even though it's a big machine. And from what I've heard, it's cost efficient in long term. And it is better for the environment to just throw the manifolds. You see here, it's the small manifolds here. It's the ULPA filter and the place where you connect the hose. And I can go back. You see here, you connect the hose. Yes. Yeah. Instead of put all the canisters from our old system in the special waste. It is expensive to send special waste to combustion, and the trailers also pollute a lot. The hospital's technical department assembled the docking station. You see the docking station here. And this station emptied the machine directly into the wastewater and clean it, and after about 5 minutes, it is ready to go again. So as you can hear, it is quite efficient as well, both during the operation and between when the cleaning staff makes the OR ready for the next operation. If the machine is not full after one operation, we can use it for more surgeries by just changing the manifold, but at a maximum of 3 times. And it is also possible to get it with a smoke evacuation system integrated, if you like that. So here are some numbers for those of you who likes that. The numbers are from a study made in Spain and UK. It's called the Green Study, where they compare closed waste management systems with canisters. You see that there's a lot there are a severe reduction in weight to handle and time spent compared to canisters. And it's a high reduction in total weight for treated waste and a high satisfaction by the users. And one of the authors of the study said, in a world where we must do things faster, safer, and cheaper, this system seems to do all of that. Yes, and then to smoke evacuation. And when we talk about smoke evacuation, I have to say something about monopolar pencils. It exists monopolar pencils both with and without smoke evacuation. You can also find reusable and those for single use. In my department, we always use monopolar pencils with smoke evacuation and those who are coated. If we forget to turn on the smoke evacuation machine, it only takes a few seconds before either the surgeon, anesthetic nurse, or the surgical nurse ask to get the smoke evacuation machine on right away. It smells bad, and they can even smell it out in the hallway. And if you are the one who forgot to turn it on, you get very embarrassed. I guess you might get used to it if you don't have smoke evacuation, but as Karam told us earlier, it is the same as 27 unfiltered cigarettes each day in the OR, and that is something we shouldn't have to get used to. And then conisation. Conisation is done with a conisation electrode and then excision of the portal. We put on a long electrode which looks like a sail. Here you see the one our surgeon can choose between. When we burn and cut out the part of the portal where there are cell changes. After the portal is removed, we put on a ball electrode. And this procedure, the whole team have a risk of being infected by HPV virus through the surgical smoke. And there is always a lot of smoke produced. Therefore, the whole team have to wear masks with bacterial filter on 98% or more as respiratory protection. Section close to the field is also important. We must cut the long section sleeve a bit shorter to get room for the electrode. This is often not enough, so we also use this isolated self-retaining gynecological speculum with suction. So you see here is a place for the hooves, the suction hooves. Sorry. Yes. If we don't use both of those suctions, our colleagues outside the OR can smell which operation we are doing. And I get a headache, which I assume is because of the smoke. We also have equipment for laparoscopy, especially when the surgeons use the monopolar hook. It produces a lot of smoke. If we don't have this equipment ready, They just open the trocars and get rid of the smoke without any filter. They are dependent on a clear view. But if we as surgical nurses are well prepared, we can evacuate the smoke through filters and then protect ourselves and the whole team, either with a short manual filter connected to the trocar, like this on the left side, or with a filter with a long section which we connect to the smoke evacuation machine. That's the one on the right side. So this was the equipment I wanted to show you. And now I want to talk about from experience to action and how to get the equipment you need to ensure safety for you and your colleagues. I wish I had a recipe for how to get your hospital to invest in surgical smoke evacuation and safer fluid management, but I'm afraid I don't. But I have discussed this subject with my department manager and other colleagues, and from that I have made a list of arguments that can help you further towards creating a safer operating room. And that is, you see here, safety first, and research, and cheaper in long term. Is that possible? Environmental arguments, and to retain employees. So, safety first. In Norway, we have a law that shall ensure safety in the working environment for everyone. And Karam also said something about laws. It says, among other things, that when it is not otherwise possible to take precautions to achieve adequate protection of life or health, the employer shall ensure that satisfactory personal protective equipment is made available to the employee, that the employee is trained in the use of the equipment and that it is used. It also says that the workplace is obliged to establish a safety representative. This is a group of people at the workplace chosen to check that the health is taken care of, that you have the equipment you need to ensure safety. These are written in one of the Norwegian laws. Maybe you have any laws in your country that says something like this, and use them as arguments. And then research. To show your leaders that you are exposed to health-damaging smoke and fluid, you must find research that proves it. And there is such research available. Karam have already told you a lot of this. These facts and numbers are excellent arguments on why your hospital should invest in equipment that can create a safer operating room and working environment for you as surgical nurses. The surgeons, the anesthetic nurses, doctors, and cleaning staff. We must take care of the whole team. And then, is it possible that it could be cheaper in long term? Surgical equipment are expensive, very expensive. You know, when you are in the sterile field and lose something on the floor and you must throw it, that feeling when you know how expensive it is. Sometimes it is better not knowing how expensive it is because the numbers are so high. Anyhow, the managers of the hospital must consider the price and costs carefully. So if you can show them numbers that in long term, the investment would be cost effective, this will be a very good argument for doing the investment. And when the Southern Hospital in Norway was considering the closed waste management system, which I told you about earlier, they saw that in long term, this system could give them lower costs. In short term, it was expensive, an investment, but in longer term, they would save money in cleaning staff, on on less use of absorbent pads and property management, less logistic, place saved, and so on. And they would save money on transport costs and environment taxes. I don't know, I don't have the numbers on this exact, but I have heard about the process, so this is worth checking out. And then environmental arguments. The CO2 taxes has increased significantly in Norway. In 1 year, it increased by 280%, and it is going to increase even more by 2030. I know that, for example, in the Netherlands and Germany, this CO2 tax also have increased a lot. I don't know the numbers for other countries, but environment has become a high priority all over Europe and the rest of the world. And a lot of countries have signed the Paris Agreement. Yes, it is 197 countries in addition to EU. And one of the proposed measures is to increase the CO2 taxes from the current level of 50 euro to 171 euro by 2030. And the leaders in the hospital needs to know the long-term effect on both economy and environment. And maybe you are the one who can make them aware of this information or tell them to check it out. Each year Norwegian hospitals sends 300,000 sharps containers and 700,000 yellow boxes for infectious waste to get burned as special waste. And Norway is a small country, so I guess other countries have even higher numbers. And transporting all of these with big trailers, often for a long distance, pollute a lot. And burning the waste also pollute a lot. I thought it would be interesting to find out what we could save the planet for by using closed waste management systems, for example. And by Googling, I found a calculator that could give me the numbers. Look here. So here is an example. I just took print screen and put in my presentation. So I did an estimate of what we use in my hospital. And it is a small hospital, so I guess most of you will have larger numbers than me. So the average number of liters of fluid, I just put on 2 liters. Sometimes it's much more and sometimes it's nearly 0. And then I chose the average of numbers of procedures, and here I chose 3,000. And the results is for 5 years. You can choose how many years you want to see the results for. And here you see some of the results. You see the difference between closed system and canisters shown by the kilos of CO2 produced in 5 years. And canisters shown, and here you see the difference between the closed system and canisters in fossil resources. And sometimes it's hard, at least for me, to understand the numbers, what it means. So they also have this way of describing it. And here you see that it's can be compared to 8 flights from Amsterdam to Barcelona you can save in 5 years in my hospital. And also 5 barrels of oil saved. And as I said, I work on a small hospital, so I guess some of you could save at least 22 flights from Amsterdam to Barcelona. And then over to the last argument on my list, to retain employees. It is both cost efficient and it is assurance quality to take measures that retain the employees. As you have learned today, smoke in the operating room creates poor working conditions. The research described earlier shows all the health risks, and it is not good to go home with a headache after working in smoke the whole day either. The headache is not the greatest risk, not the greatest at all, but it is what I have experienced on days with more smoke than normal. And can I work for many years in these conditions? And will I expose myself to such a risk? And what about all the suction chambers carried, fluid spilled, the cleaners' back problems, muscle and skeletal disorders, or a common, yes, the muscle and skeletal disorders are a common cause of sick leave. In Norway, it represented 32.7% of the days with sick leave. For employees in healthcare sector, as in hospitals, the numbers are even higher. And there are documented that mechanical exposure can relate to muscle and skeletal disorders. We must take care of and strive to keep our skilled and experienced employees. And there is a huge potential in preventing and then reduce diseases. Sick leave notification and use of substitutes are at least expensive and can compromise safety and work environment. Ripple effects. This was the list we made of arguments. Maybe some of you can think of others, or maybe you don't find all of them fitting for your workplace. Anyhow, I hope this could be of interest, and maybe it could inspire some of you to work for better conditions in your hospitals and ORs. Hopefully you can get the whole team together working for a safer OR. That is your working environment. Thank you for listening. And here are some sources. Yes, thank you.
Thank you, Anne. Now it's time for questions and answers. Bruno from the north of Portugal asked, do you use surgical smoke evacuation systems in all surgeries? And if yes, you have a special protocol for the system? Do you see the question?
Yes. We don't use it when we use those bipolar pencils. But in those procedures with a lot of smoke, we use it. And we have those protocols for each surgery, which equipment we shall use, and so on. And it stands in those, if that was protocols, if that was what they meant.
What was your experience in France, May?
In France, we don't have, we are bringing awareness, but we don't use in several hospitals, we don't use devices for surgical smokes at the source. Sometimes they use the suction, the classic suction, you know, for fluids, but it's not effective, and the filter is not the right filter, and the masks are not protective against smokes. But for fluids, in several hospitals, they begin to use devices for suction of fluids, direct suction, without using the canister, like Mrs. Helland showed us.
Any other questions? May I could pose a question? Could we accept that inside of the operating room, we don't use exhaust systems for surgical smoke? And for some cities, it's an obligation to use a car with the catalyst in the exhaust pipe. Do you understand the concept?
Maybe I'm afraid it's for me the question, or
For anyone.
for anyone. For me, I think it's a pity that we do not use devices, because several studies showed the danger of those smokes and the risk for healthcare professionals. What can I say? Is it at least for special procedures, not for all procedures, because some procedures does not produce so much smoke, just if it's for the skin, and then that's all. It's maybe it's okay, but for conization, yes, and laser procedure, and hip replacement, and some other procedures. I think we should use this, but is it a question of cost? Is it a question of lack of awareness?
Any comment, Han? Any other questions? Any other comments? All the people is very shy. Oh, there's a question. The commands are shit. Oh, no question. Okay. If no one's want to ask Han or May, I think that we could finish this webinar. I think that, wait. There's a participant. No, it's not I'm in Canada and I use smoke evacuation in most surgeries. It's a comment from a anonymous participant from Canada that use almost the times smoke evacuation systems.
Great. Let's hope this for all the countries.
It needs to start in any place. Okay. Perhaps we could close this webinar. Thank you, Anne. Thank you, May. Thank you, Ford
Manuel.
Striker, to support this webinar, and see you soon here or in any place.
Thank you, Eorna. Thank you, Striker. Thank you all. And thank you for all the person present.